My name's Hamish MacLachlan. I'm one of the cardiac research and the young research fellows. It's a great privilege to be able to talk to you today about some of the fantastic work that's come from the ECG-based screening program delivered by Cardiac Risk in the Young. I'm going to report on two studies, one of which is currently unpublished, looking at initially the cohort of athletes screened and then later a larger cohort of young individuals from the general population. Hereditary and congenital abnormalities of the heart are the leading cause of non-accidental death in young athletes. The incidence of sudden cardiac death is relatively low, and when we review the studies with high methodological quality, an estimated 1 in 50,000 person years is generally agreed. Prevention of these tragedies has become an important focus of the medical community, either through primary prevention with early detection of disease through screening or through secondary prevention with effective CPR. There has been undoubtedly fantastic strides forward looking at the early availability of AEDs and effective CPR, which is undoubtedly saving lives. When we look at studies evaluating young sudden cardiac death, it would appear, however, that a larger proportion of these is occurring at home and also in sleeping hours. The most persuasive evidence that early detection of the diseases saves lives comes from this eminent study from Italy, where, as we've just heard, ECG screening is mandatory by law. This study, which you're all familiar with, has reported an 89% reduction in the incidence of sudden cardiac death in athletes over a 25-year period. Based on these findings, the ESC has recommended ECG screening on legal, ethical, and medical grounds. Despite this, in the majority of countries, cardiovascular screening with the ECG is reserved for elite athletes. Indeed, the ethics of limiting screening to competitive athletes has been questioned, and particularly when we review recent data from Denmark, France, and the USA, which suggests that the incidence in both recreational athletes and also the general population is higher than previously thought. To drive the debate forward, our research group has taken advantage of the data from the fantastic ECG screening program delivered by Cardiac Risk in the Young. As mentioned, I'll now report on two studies, and I can't take the credit for this. One of our fantastic previous fellows, Dr. Harshal Dutia, who sadly can't be here today, has done a lot of work in contributing to these studies. I'd like to start by just telling you about the outcomes of 5,000 elite athletes that were screened by Cardiac Risk in the Young over a 3-year period. Of the 5,000, they were all screened for the first time, and this was a mandatory requirement of their national governing body. As you'll see, the majority of them were male, the majority of them were white, and they represented 26 different sporting disciplines. Of the 5,000, 11.2% were referred for secondary investigations with an echo, 1.7% with a treadmill, and 1.2% with a Holter and a cardiac MRI. These secondary investigations identified 15, representing 0.3% of the cohort, with conditions associated with sudden cardiac death. This came at a cost of €95 per athlete and a little over 31,000 per cost of serious diagnosis. Harshal went on to apply more contemporary ECG criteria, initially the Seattle and then later the refined criteria, and was able to reduce the proportion of abnormal ECGs to less than 5%. Contemporary ECG interpretation criteria decreased the cost significantly without compromising sensitivity. As you'll see, all 15 individuals with serious conditions were identified, and there was a cost reduction of 21%. This, of course, may be cost permissive for many sporting organizations. Currently, the routine use of the ECG in screening young asymptomatic individuals is not currently practiced, and this is reserved, certainly in this country, for individuals with symptoms, a family history, or an incidental abnormal finding on physical examination. The routine inclusion of the ECG in a large cohort of the general population has not been scientifically tested until now. The second study I'd like to report on, again led by Harshal Dutia, which is currently unpublished, looks at the report of outcomes in a nationwide ECG screening program in adolescents and young adults. So over a 3-year period, again, a much larger number at 27,000 young individuals aged between 14 and 35 years self-presented for cardiac screening with cardiac risk in the young. Evaluation was carried out by a cardiologist with a background in inherited cardiac conditions and sports cardiology. They underwent evaluation with a standardized health questionnaire, a physical examination, and a 12-lead ECG. Individuals with abnormal screening tests were referred for secondary investigations and were prospectively followed up using a standardized health questionnaire, a patient questionnaire pertaining to outcomes and investigations. There was also calculations of the workload and cost implications of the screening protocol. A quick look at the demographics. The age was almost exactly the same as our elite athlete cohort. Again, the majority were male, the majority were white, and as we'd expect in the general population, a much lower number of 4.5 hours per week. So, proportion of positive screening evaluations. You'll see here that 3.5% of the 27,000 almost individuals were referred for secondary investigations based on an abnormal health questionnaire and physical examination. A much larger proportion of individuals, 8%, were referred for investigations, secondary investigations, due to an abnormal ECG. In terms of what investigations they were referred for, you'll have to take my word, they were very similar to the athletic cohort. Again, 12% with an echo, 1.7% with a Holter and a treadmill, and 0.9% with an MRI. So what did we find? Well, if I can turn your attention to the left side of this figure, you'll see that 90 of the 27,000, that represents again 0.3%, of the entire cohort, were found to have a condition associated with sudden cardiac death. And you'll see here that it was the ECG that identified 80%, so the majority of these diseases. It was the history and the physical examination that largely detected ion channel and connective tissue disease, whereas the ECG detected all of the cardiomyopathies, congenital accessory pathways, and some of the ion channel diseases. At 2 years follow-up, disease-modifying intervention was initiated in 44% of the individuals with an abnormal history and physical examination, and a larger proportion at 60% of individuals with an abnormal ECG. With regards to cost, an additional 72 serious conditions were identified through the inclusion of the ECG, giving a cost per serious diagnosis of €27,500. When we think about evaluation with the history and physical examination alone, this was associated with a 40% increment in cost per serious disease. The savings generated by the inclusion of the ECG would comfortably allow for affordability for additional costs such as risk stratification, genetic testing, and familial evaluation, and still be cheaper than the cost per serious condition identified with history and physical examination alone. You'll have to excuse me for the absence of statistical testing on this table. I've just drawn up the outcomes side by side of our athletes and our non-athletes. And you'll see here, of course, the cohort much bigger in size for our non-athletes, but you'll see that 12% for both the athletes and non-athletes were referred for secondary investigations. And the majority of that was based on the abnormal ECG. With regards to prevalence of conditions associated with sudden cardiac death, this was identical in both cohorts. And you'll see it was the ECG that was by far the most sensitive screening tool. With regards to cost, they are fairly similar. Of course, we must take this with a pinch of salt. Screening the whole entire general population will, of course, be associated with additional logistical costs. In conclusion, this is the first reported nationwide screening program outside of competitive sport. The routine inclusion of the ECG improves the diagnostic yield by 5-fold. It improves the rate of disease-modifying therapy by 20% and is clearly associated with a superior economic profile. These findings have the potential to influence healthcare policy and suggest that the current Western healthcare system to identify individuals at risk of sudden cardiac death is counterintuitive and may require revision. A little bit about moving forward and where we're turning our attention. The group at Cardiac Risk in the Young, we believe that the pre-participation screening program can be further optimized. We're looking at streamlining the protocol further by introducing a more objective health questionnaire, which has been designed to be delivered without an on-site physician. We also want to provide a focused echocardiogram protocol to be delivered on-site, which may save time and cost. We also want to turn our attention to further reducing the number of false positive ECGs, particularly in Black athletes. To date, we've mainly turned our attention on the positive findings from the ECG program, but we want to look further into the negative findings. Particularly using a national registry, we want to look at what the incidence of sudden cardiac death and sudden cardiac arrest is in the entire cohort of those screened by Cardiac Risk in the Young, which is coming on to 100,000 individuals. And I look forward to telling you about some of this fantastic work in the years to come. Finally, just some acknowledgements. I know I've mentioned his name before, but potentially Harshal Dutia, who sadly can't be here today. He couldn't have done that without the further support of those listed there. Thank you very much for listening.